Welcome to the show. It's fantastic to get you on. Of
Absolute pleasure, Andy. Appreciate the invitation.
course. So obviously we met very, very briefly in passing in LA at the Sportsmith conference, which is when I kind of tried to strong arm you into coming on the show. But just in case someone hasn't come across your background or wasn't at the conference, can you walk us through your background?
Yeah, you didn't have to work too hard now. It's an honor and a privilege to be on the podcast with you. Yeah, I am head of elite performance and development in Aspetar. I've had the pleasure of being there for the last 3 or 4 years now, working with a fantastic team. A physiotherapist by trade, but combining rehab and S&C and biomechanics. My PhD was around the role of biomechanics after ACL reconstruction, and I've done a lot of work on athletic groin pain and more recently on chronic and recurrent thigh muscle injuries. My role involves looking after a number of international athletes, but primarily working with the team we have in Aspetar, trying to evolve our clinical pathways, our systems, and the research that we do around that year on year. Our practice is evolving and we're offering the highest level of care.
Obviously, you kind of have like I guess like an interesting ecosystem around you in terms of, you consult, you do research, you're in a very senior role at Aspetar. I'm just really curious, kind of at your level, I guess as a clinician, how do you now sort of stimulate your growth and development? Obviously, research always keeps people current and in the future, but how do you sort of push yourself forwards now as a clinician?
Yeah, definitely. I think that the research is an aspect, but I think collaboration is really important. I think you reach a certain level in your career and you do some stuff and it works fairly well. But then actually by working with other practitioners within the team, or by collaborating, we've just been recently over with Paris Saint-Germain for the last couple of days, sharing ideas around what they do in particular. So as you collaborate and as you work with colleagues on evolving your systems on a year-on-year basis, it's like everything else. You see what you don't know, and it really highlights. I suppose when you're at a centre like Aspetar and you're having probably, let's say 200 ACLs a week, maybe 25 athletic groins and maybe 25 hamstrings, you get to see a lot of stuff. And given that, at any given point in time, at least 10% of them will be really tricky. It's the difficult cases is where the interest is now, and fortunately or unfortunately, I get to see less of the acute stuff, and most of that does well and recovers well. But when you've in a high volume centre like Aspetar, you've lots of great minds around you to brainstorm and troubleshoot, and B, you get lots of tricky cases. So it really challenges your processes, really challenges your paradigms, and you two given athletes with the same MRI, and one's getting better and one's slower to get better. The question always is, what are we missing here, and what's the added component that you're looking for? And so those difficult cases are really the ones that keep you striving, and then also they drive your research questions going forward. So I think collaboration and working in a centre where there's tricky cases at least keep me on my toes on a day-to-day basis.
Yeah, do you know, I knew you guys saw a high volume of those types of injuries, but I didn't realize it was quite that extreme. Even if even like, you said the tricky cases, even the volume of tricky cases that you get to see is actually quite staggering compared to, a normal private practice or let alone a team. So
Yeah,
very cool.
absolutely. I mean, a team would be hoping for maximum one, maybe no ACLs per year. In fact, with an NBA team recently that we were supporting, I don't think they had one in somewhere between 8 and 10 years. So they're at the top of the game of what they're doing. But, when you haven't had that recently, it's good to be able to touch base or lean on a centre that has that high volume, maybe has made those mistakes and then has evolved their systems accordingly. And that's where the ongoing growth is from.
Yeah. Obviously, the big kind of clinical topic that I want to get into today with you is athletic hip and groin pain, and sort of rehab around that. It's probably an area that I see even less of. Like most of the work I do now is tendons, so I never see an athletic hip and groin. So it's a very selfish episode for me to be able to pick your brains. I'm privileged, but from my perspective, especially diagnostically, it's an area where clarity is of particular importance, and sometimes a challenge. You clearly can consult widely across sport. If we can make a kind of sweeping summary, what presentations or conditions under the kind of hip and groin umbrella do you think typically practitioners diagnose well first, and we're kind of, what are we good at in that space across the board?
Yeah, I think the acute hip and groin injuries are well managed. Or sorry, acute groin injuries are well managed. They're not something that tend to call practitioners or coaches a lot of angst. They do quite well. Even the higher grade avulsions seem to might manage quite well, whether you do it conservatively or whether you do it operatively. And I think we're quite good in our timelines. We're quite good at lowering them back progressively, getting strong in the areas that have been acutely injured, and reintroducing training loads at an appropriate point of view. So I think the acute stuff is very good. Within the chronic stuff, I think the pubic bone edema is probably the easiest one to diagnose. I think people are quite consistent on that. It's when you get into the other musculotendinous side of things that it gets a little bit more misty, so to speak.
Do those tend to make up more of your kind of problem cases or tricky cases that you get the second the second opinion referrals for?
Yeah, I think there are some second referrals on the higher grade of ruptures as to do we go conservative or do we not, or we've reached a certain level of conservative management and we're plateauing. But often that's just reassurance, and that the research suggests that whether you repair it or not, but a lot of the time you don't need it to, and it does very well. I think it's when it comes to the other aspects of the chronic side of things, it's the probably three things: that the lack of clarity about where the pain is coming from, the lack of clarity about what to do next, and perhaps when you've had a few recurrences, maybe a lack of maybe a bit of reset in the process as to how can we recalibrate and where to go from here. So I think that's more or less across all of the rest of the pathologies of musculotendinous, whether you group them in terms of adductor, inguinal, iliopsoas, and even the hip joint itself. And there's probably a number of reasons for that. First is that our clinical tests they're sensitive, but they're not that specific. So they're very good at reproducing pain. They're just not very good at telling you where that pain is coming from. And that makes, depending on your experience in assessing these injuries, but also similarly with your clinical palpation skills, it's very difficult to be discreet about what exact structure you're on. When you're pressing on the pubic tubercle, am I really pressing on bone or adductor tissue or abdominal tissue, so to speak? And same, there's often, especially by the time, I suppose, biased again, that I would get to see them, they often have multiple sources of symptoms. So it started off in one area and then kind of spread to the contralateral side, or maybe more proximally or more distally accordingly. And radiology has a lot of false positives. And we've seen that in the hip joint, where 80% of athletes will have a labral tear and be completely asymptomatic. We've seen it in the pubic bone across a range of court and field sports, where bone edema is quite common in asymptomatic athletes. There's a lot of changes, especially around the fibrocartilaginous aspect of the adductor longus, or cleft as they call it. Lots of abnormal findings in healthy athletes, and increasingly lots of posterior wall weakness or bulging in athletes that have had absolutely no pain whatsoever. So your clinical tests make it difficult. To be specific, your palpation makes it difficult to be specific, and the radiology can send you down a false avenue. And so a lot of the times then it's there's a focus on where the pain is coming from, rather than necessarily what's driven the pain to develop, especially on the insidious onset and more gradual presentation. So it's not an easy solution by any stretch of the matter.
How do you kind of proceed in that situation in terms of I guess there's always first a question of kind of, and I think you said this in LA of, is this for rehab or is this for something else? Is this for surgery potentially? But how, I guess a two-part question, how do you decide that? And then if it's not surgery, how much do you park aside the complexity that you get from imaging, special tests, how discrete it is, and just focus on function?
Yeah, I think if you look at if we take a group of people, let's say, even we talked about at the conference, but let's say you take 10 practitioners, it's very unlikely those 10 practitioners are going to come to the same kind of consensus on what the diagnosis is. So I'm not saying don't bother, but it's unlikely to improve the consistency of our care. The bigger inconsistency in our care is that, depending on what we call it, let's say myself and yourself call it two different things, Andy. if we end up with different management strategies off the back of that, whether one is surgery, one is injection and rest, and one is rehab, that's three potentially very different outcomes. Whereas if you call it one thing and I call it the other, and we both decide it's for rehab, well, then does it really matter what we're calling it? Especially considering they probably have a couple of sites of symptoms. So I think really in that initial triage, yes, we'll do our best to be specific in where we're bucketing the diagnosis. But the number one thing is it something that needs other management, like a stress fracture of the neck of femur, maybe any kind of slipped epiphysis or issues in and around the hip joint, any other kind of systemic or medical conditions. They're really important to pick them up and make sure that they're managed appropriately. And they're the minority, but still, when you fall into your tricky cases, they're the minority that we have to be very, very, very aware of. And then once you've decided it is for rehab, there's really three. When you're managing any chronic groin, there's really three legs to the stool. Number one is load. So obviously, if you're not playing and training, you're highly unlikely to get pain. So how do I minimize your load to let your symptoms settle down, but then build it back up appropriately? Number two is your anatomy, both really in terms of its irritability. So is that area calming down on a 48-hour basis? To reflect A, that my rehab strategies are working well, but also B, that my reloading is appropriate. And then number three, probably obviously where my main interest is, what's the drivers in terms of the pathomechanics about how that area develops symptoms in the first place. We have a habit of treating our chronic groins like our acute ones. If you acutely tear your adductor longus or your iliopsoas, that tissue needs to be loaded. It needs to be loaded eccentrically, it needs to be loaded progressively and into range-specific movements. But in many of our chronic groins, that tissue is overloaded and needs to be, I wouldn't say left alone, but the dysfunction that's driving why it's compensating for other parts of the lumbopelvic region or even more extensively proximally distally needs to be identified while we're concurrently settling the symptoms and while we're concurrently managing your load, because we've all seen athletes where we've rested them, their symptoms have settled, we've reloaded them in a way that seems fairly appropriate, and then they redevelop symptoms again. And then we go back and second guess the anatomy and the diagnosis when perhaps the diagnosis was always accurate and maybe didn't really matter so much and didn't address or change the rehab factors that were most important.
Let's say you kind of, you've done your imaging, you've done your special test, you've got to the point where you've got your diagnosis or your kind of working hypothesis for what the problem is. And let's get into kind of some of the stuff you were talking about then. You want to look at maybe some of the biomechanics or key kind of functional capacities that could relate to contributing factors or reasons for this to have occurred. What are the sort of like key things that you're going to look at functionally for this?
Yeah, I think you can start at either end. You can start at the high-end activities, depending on their level of irritability. So watching them run, jump, change direction, whether that's visually or with a camera phone or obviously in a biomechanics lab as we do, and break it back into the simpler things about your range of motion, your motor control around the hip joint, the trunk, etc. So you can really take it on that spectrum. But at some stage, you want to have gone through what their motor control is like, primarily in and around the hip joint, but especially around the trunk as well. And then obviously more proximally and distally, whether that's shoulder motor control in a throwing sport or foot and ankle in a football or basketball player. Obviously that's important, but the strength and power that you have and that you can produce during that, it's not uncommon for us to see old ankle injuries or ACLs, etc., go on to develop groin pain. So have we redeveloped strength and power sufficiently of those? And then how they use those base physical qualities and coordination in sports-specific activities or in activities that are aggravating their symptoms. And so at some stage, either at the beginning or at the end of rehab, we need to come along that spectrum of having checked each of those boxes and how they contribute. Where I suppose my practice has evolved is, I've done the motor control work, but then haven't progressed that on to the mechanics that was aggravating in the first place, or I've done lots of coordination work and I haven't regained that fine motor control around the hip joint in the same way that we do with the shoulder. Like practitioners are very good at, isolating the cuff work, redeveloping into patterns and progressing from there. Sometimes with the hip, we just load it, then we get back into our squats and we get back into our hip work, which is very, very, very important once complemented with the other coordinative work when it's required. And I think as time goes on, and as I said previously, when you have high volumes, you get to see the outliers. And so less and less and less will your diagnosis tell me what your physical deficits will be or what your injury history will be. And so it's very important to start with a blank canvas. Not that you do it all on one day, depending on whether you work in private practice with a team or how irritable their symptoms are. But over that first week in particular, you start to get a very complete and holistic picture about where that athlete's at and what their contributing factors is while their symptoms are settling down and while you're deloading them to allow that to facilitate that process.
Do you, obviously, like if somebody's got a previous injury history like knee or ankle or shoulder or something like that, you're gonna test them on a very nuanced individual basis there. Is there any kind of bigger global movement patterns that you might assess objectively, with force plates, cameras, kinetics, kinematic kind of tools? Is there any kind of like, I hate the sort of absolute questions, but is there any quick and dirty tests functionally that you might look at for global patterns in most athletes, let's say?
Yeah, I think our test battery is fairly consistent, almost irrespective of what the injury is, or fairly holistic, almost irrespective. There are one or two specific ones, but by and large, you'll have your compound movements, which would be double and single leg squat, double and single leg calf raise, lunge and single leg RDL, and you'll get a very good idea of what the global patterns are with that. This is specific for lower limb injuries. We'll then look at their explosiveness and reactive strength, usually with counter movement jumps, drop jumps and hop for distance. We'll then put them on an instrumented treadmill. Again, the speed, and we're doing some work on that currently about how much the speed will influence the main biomechanical drivers that we will see. Do we have to run, if we run them at 10k an hour or 15k an hour, is that enough to see the main components? And then we'll do change direction tests at always 90 degrees, planned and unplanned, and then maybe some others depending on the individual sport per se. And at the end of that battery of tests, we'll have a very good idea of what their coordination is like, what their performance is like, and then what their pathomechanics are like specific to certain activities. And you can wrap that in with isokinetic strength or handheld strength or whatever your other global and local strength measures are. But that tends to be the battery of tests we'd run through. And whether you're an Achilles rupture or whether you're an ACL or whether you're a groin, that kind of battery will identify where a lot of the, I suppose, that vocabulary, that fundamental is almost the same, irrespective of the injury and irrespective of the sport. And then you will layer on top of that the more individual aspects and more sport-specific components appropriately.
Yeah, I want to take a different route with this to how probably the listeners are expecting, because we've kind of spoken a little bit about the challenges of the injury from an assessment perspective, then how you kind of functionally get there. And they're probably expecting us to go on to rehab, which we will. But they're probably expecting me to then say, well, what do you do? But obviously it's just going to be dependent on what you find case by case from all those tests. So we're going to pivot a little bit in terms of how we do the episode. So to kind of segue to rehab, one of the things that you mentioned in LA was your kind of 3 core principles of rehab, at least for this area. And they were that the first one was begin with the end in mind. The second one was you see what you look for and you look for what you know. And then the third one that you had on your slide, I remember, was did you do what you said you were going to do? And I'd kind of love to explore these to kind of tease out philosophically kind of how you approach rehab more than anything. Begin with the end in mind is something that people will logically just understand as a statement. But I guess what I'd love to know is how do you, in a more tangible way, with all this complexity, how do you sort of plan the process? And I know that sounds like a really simple thing, but people will, I'm sure, listen to you present and listen to you on podcasts like this, and then they've got to go to work tomorrow and actually execute some of the things they've learned, hopefully. So I'm just kind of curious how you put pen to paper and strategically map this process out. Obviously for you, I'm sure you've done it thousands of times, but I'd just love to know the structure.
No, it's been a real North Star for us in Aspidar in terms of when we're reviewing our processes and kind of agreeing how are we going to rehab a groin or how are we going to rehab a hamstring or an ACL, is trying to get trying to get clarity about when the end comes, what do we want to have done, and that can be on pitch, GPS, sport specific stuff. It can be strength and power, motor control. So what are all the various qualities we want to have analysed? What does good look like, whether we're right or wrong? What threshold do we want to set as appropriate for that? And what level of reconditioning do we want to have done with that athlete, whether it's metabolic reconditioning or specific to their sport? So that's number one. And the second thing then is, so is specific to groin, where begin with the end in mind is important is in, if you've left a number, if you're just working through your rehab and you haven't considered all of the potential contributors. In the easy ones, it won't matter because they're going to get better anyway. But in a large proportion, especially these chronic ones, which are stubborn, I need to be aware of all these factors, and I need them to be progressing over time. And nothing is worse that I get to what I think the end is, and I'm not where I need to be. And so having that clarity at the beginning of the process is really important about all the various factors. And as I said, when you're in private practice, it's not like you need to assess it all the first day, but you need to be aware about as you're going along where to go. The second area we run into trouble in chronic groin in particular is my key milestones or KPI throughout that process. So what do I want them to have achieved when they go back running? What do I want them to have achieved when they go back, change direction, when they go back into training, both in terms of from a rehabilitation point of view. So, but also from a pain provocation point of view. So an example in the pain provocation would be, I would want all my athletes to have a pain-free. This is something now that we're rehabbing to get rid of it, as opposed to managing, because we have a Champions League final next weekend. But I would want all my athletes to have a pain-free crossover test. So in a Thomas test position, resisted hip flexion, not bringing on pain on the contralateral side, before I go into my running drills and running volume. The reason being that if I can't flex one hip without being sore, I'm just going to poke the bear. Okay, so even if my rehab's outstanding, that area is irritable, and I'm going to be loading it at a level that's just going to continue to piss it off. Similarly, I'd like to have regained symmetrical hip internal rotation and a pain-free squeeze at 45 before I'm more aggressive on my change direction drills, because ultimately that area has to settle down. And so continue to kick the bruise, so to speak, is just going to prolong the process. But concurrently, what do I want when I do go back running? What do I want my motor control and strength like when I do go back, change direction? What do I want my running volume to have been at that given point in time? And so begin with the end in mind. Just really makes you draw the buckets that you think you need to consider for these athletes. And it's a process we go back through every single year, because A, it's amazing what you forget. You start leaving out buckets and you don't know why. And then B, there'll have been those special cases that made you make your buckets bigger accordingly. And the second one then is drawing that roadmap, because if you're someone that's painful for a week, or someone that's had an ACL injury, or someone that's, symptoms for, they have a different journey about how they're going to get to that endpoint all the time. And so we need our milestones and our KPI to make sure that regardless of where you start in that journey, we're going to start narrowing in your processes very, very quickly. And that's going to ensure the greatest consistency across all the staff in what we're doing, but hopefully it'll see the greatest consistency in outcomes and speed of outcomes as well. And where I see people running around is, I start my rehab, but I'm kind of working through it without necessarily that end goal in mind. And I start reintroducing pieces without necessarily my base practice to reflect back against that. If it doesn't work out, what am I going to reflect back and say, actually, this is where I went wrong, or my processes didn't work, so therefore there's something new I need to add into what I'm doing.
Yeah, no, I love that. I think there's often a case of sort of like midway through a rehab, if things aren't going well, if you've planned it, like you said, with the end in mind from the beginning, you are where you are and you know what you've got to work on against your principles, versus if you're not sometimes, and then you haven't gone through that process, there's kind of this, where should I be right now? And should I just be doing that regardless of the state of the athlete? So, yeah, I really appreciate that. The second one was, you see what you look for and you look for what you know, which in a general context kind of makes sense, but can you expand on it from a rehab perspective? Maybe hip and groin, or just rehab in general?
Yeah, I think in hip and groin, it's easy in one way. So like we would all assess strength around the hip, just as an example, but very often we don't look at motor control around the hip. So for example, we will test hip abduction strength, but hip abduction strength is greatly influenced by glute min control, or that active versus passive hip abduction. So same as you have in the shoulder, if you don't have a good cuff, whatever the hell a good cuff is, it's going to impact the force you could produce in your pec, in your lat, and in your deltoid. So we often tear into our hip strengthening without necessarily a good understanding about, do I need to strengthen that muscle, or do I need to improve the control around the hip to let me express the strength I already have? The same could be same for the hip flexors. Very often we get adductor overload, especially in the sagittal plane in hip flexion exercises, but it's nothing to do with adductor weakness. Often it's to do with iliopsoas weakness. And if we look at our force framework at 90, yes, it'll give us an output, but actually it's an inner range hip flexion is where iliopsoas is a mechanical advantage, and you can isolate deficits in the own. Same around the posterior hip. The deep rotators are incredibly important stabilizers for both the hamstrings and the glute max to express that hip extension strength. But if we never look for it, we never see it. And so you see what you look for and you look for what you know means that when your rehab isn't being as effective as you like, or maybe plateauing, do you continue doing more of the same, or do you step back and say, actually, and once you see it, you never miss it again. That's the other side of it. Like every good workshop, every good course I've ever attended, there's been one or two things you're going, oh shit, I missed that. I like that. That's what was that. That was what was wrong there. And again, that's where those tricky athletes help broaden our components as well. But the same comes with kind of the biomechanical aspect of it. I've been saying to death that I've been very fortunate to work probably for the last 15 years plus, both in Dublin and here in Aspidar, where there's been a biomechanics lab. And it's been fantastic for a couple of reasons. Number one is it's good for hammering your bias. That's number one. Number two is it's quite humbling to have your work reviewed every 4 to 6 weeks, and there's these changes you think you've made, and then you're reassessed, and really has it made the changes that you thought it did. And number three is, we're focused here, for example, on the hip and groin, but obviously it's a whole body assessment. And so you start seeing things proximal and distal to the hip and groin that are having a massive impact, and you just either haven't looked for it or you haven't done anything that's gone on to change it. So I think in a layered way, we can watch someone run and we can look at their speed. That's beautiful. And we can video them and we'll see how they move. So that's a second level up. But we can't see forces. So, you do a biomechanical analysis. So I think with you see what you look for and you look for what you know. It's that the more holistic you are, the more things you'll find. Whether they're relevant or not, that's up to your clinical reasoning. But secondly is, even when you're looking at something, there's layers of depth to what you can get out of it. So you do a counter movement jump, okay, there is the performance element of it. There's the forces you're putting into the ground with the force plate. There's the levels of movement that we can see. And then there's the force at individual joints in the body. And you don't need them all, or you may not need them all, but they all have information that contribute to it. So when you don't have them, that's not a problem necessarily for your practice. Once you've an awareness that there's a limitation to what I'm able to get from this particular test at any given point in time, specific to how I'm doing it. And once you have that awareness, your shadows and your blind spots will get much, much smaller when you're clearing athletes, or you're thinking, right, that's competent, when actually it'll allow you to recognize it's competent, it's better, but are there particular cheats or compensations still there that I'm just not measuring with my metric?
Yeah, I'm sure this next one, I'm guessing we'll probably close the loop, but the last one was, did you do what you said you were going to do? Can you expand on that one lastly for this kind of trio?
Yeah, I think it's one of the great parts of some of the workshops we do is that, I think the number one thing for me in groin for us as a group of practitioners is, do we agree someone's for rehab or not? Okay, that's a big improvement in the consistency of our processes. The second thing would be, if we all assessed the same athlete, would come up with 85 or 90% of the same to-do list. And that's because if you see things that I don't see, then your ability to be precise and accurate and individualized would be better than me. And the third one then is, can we change it? So we're quite good at writing exercise programs down, and we're quite good at reeling out the Instagram videos. But when you go back and reassess them, has anything changed? And this is really powerful in the motor control side of things, where you let's say we've a glutamine an iliopsoas deficit, just as an example. And you ask the group to do various exercises, and they'll go from one to the other, and you retest them in inner range, and it hasn't changed. And it's not that the wrong exercise, but it's in the ability to see that exercise at that level is not going to make that improvement for that athlete. And they'll point to their rec fem, or they'll point to their TFL, or they'll feel it everywhere except where you want to feel it. And so on those fundamental control deficits, I think, being able to be clear on the changes you're making are really important. And then similarly on the higher level biomechanics, like you can do lots of jumping, lots of running, but if you think that a large pelvic drop or a large ipsilateral trunk rotation during running is important for adductor loading, which I think it is, if it looks the same in 6 or 8 weeks' time, well, of course, under the same load and under the same conditions, it's liable to become symptomatic or irritable again. And one thing I suppose I've been fortunate in treating a lot of groins is that if they're grumpy and they're sore, unless you start ticking the right boxes, they stay grumpy and sore. And so it's a very, very good feedback loop. So if your symptoms are not improving 48 hours under appropriate loading, I'm missing something, right? I'm missing something in my assessment, or I'm missing something in my intervention. But even without the symptoms improving, we should be able to see when we retest these various components that we're getting the change. And do any exercise you want. Like certainly in our work in Aspetar, we have a very broad curriculum of exercises that we can focus on. So you pick whatever you want, and that's part of the fun part about what we do. But we're happy to be held accountable to, did we get the change we're looking for? And if we didn't, is that because I didn't pick the right exercise? Is it because I didn't coach it properly, especially on some of the more coordinative and motor learning exercises? Or I didn't periodize it properly, in that I just didn't get the stimulus that was needed progressively over time to do what we're looking for. So I think, as I said, both with groins not responding, but also with the reassessment, the biomechanics lab, did you do what you said you were going to do, or do I blame the patient, or do I blame the athlete, or blame the anatomy as they're not getting better because of X, Y, and Z, when perhaps it was just my ineffective programming was what was letting the show down.
Cool. No, I love that. And those 3 points definitely resonated with me. And there was a few others from other presenters, including yourself, that kind of that just for me really hit home when I was listening in the audience. And I'd love to share the ones that stood out to me, including another one of yours. And then what I'd love to do is see if you took anything differently from them, or if there's anything from the conference that you took that added to how you kind of approach hip and groin as a philosophy. And the first one was Robin Thorpe, and it was being outcome based, process guided, and adaptation focused. Romain Touron, who I probably butchered his name for the second time on our show, his was to kind of keep things simple and do the foundational things well. And then from both Bill Knowles and from Alan Murdoch, it was the power of movement patterns and how to use and trust your coaching eye. And then the last one, which you kind of touched on then, was what are you working on, and did they feel it there from a sort of intervention standpoint? So I'm just kind of curious, would you expand on any of those, or was there any other kind of take homes for you just sitting in the audience, maybe from other speakers?
Yeah, no, I like, it was a fantastic program, to be honest with you. It was, my head was buzzing for the 2 days after. I'd agree with all of that. I really liked Robin. I spoke to him about it afterwards. Knowing your tests, knowing your data, knowing what's real change versus, and real information rather than just collecting noise. He was really, really good on that. I obviously love Romain's work because we're of a similar mindset in terms of the steps and the processes to break something down to build it back up again. I thought he has tremendous detail on his ankle stuff, and took a lot from that. And Bill and Alan, you could listen to them all day. I think that functional movement and reconditioning the athlete is something that I espouse to a lot, especially with your ACLs and your groins in particular. And the coach's eye and being able to see things is really important. I suppose to add to that, probably not having a biased coach's eye is probably where the lab has pulled me out of that a little bit, in that going back to, you see what you look for. So if you're looking for certain things, you'll always see them, or you'll miss other things. So evolving that eye over time is really important, especially in those experienced practitioners. In terms of other ones, Keith Barr, like, I take in about 10% of what that man says every time I listen to him. But it's almost the opposite of what we've just talked about, in that, when you're obviously his work is in tendon tissue, but understanding when you're applying a stimulus, how it affects, at a tissue level. So like, we're espousing better to the coordination, the motor control, and the bigger movements, but also being able to come back down the ladder into very clearly understanding how you can influence pathological tissue with the stress you put on it, and your considerations around that. I always take a lot from that. And I'm a bit biased, obviously. David Power works with us here in Aspetar, and really liked his hamstring case to fit in probably with the point that you raised for me, in that, when you look at those high level, high grade hamstrings, the levels of compensation that you can have, and so you can be doing your strength work, but you can get a huge, compensation with semi-mem or the short-headed biceps femoris, or you can be doing lots of strengthening work, and you look at the EMG and it's radio silence as you go along. So I think that goes back to are you doing what you think you're doing, and then B, for all the technology around EMG, etc. If they don't feel it in the long-headed biceps, you're probably not doing it right. Or if they don't feel it in their VMO, they're probably not doing it right. And that's the number one action above all things. then if they feel it in the right spot and at the right intensity, there's a very, very good chance that you'll get the adaptation you're looking for. So I loved all of those presenters. As I said, Keith was nice because it was almost like a more localized version that we can be in danger of brushing by. And then I suppose David would reinforce that aspect of, let's be honest, like especially with soft tissue injuries, 80% get better no matter what we do or in spite of what we do. But the 20% are where we get caught out, either not having the right pathway or making assumptions on what's important or making assumptions that my stimulus is being effective. And I think that can definitely happen in groin, where we are narrow in what we think is involved. You know, I squeeze my knees together, I have pain, therefore I need to do more squeezing together, which may not necessarily be the case. And also, if we've too narrow a view on what the issue is, and especially when it comes to the contralateral side, sorry, I probably digress from this above, but you know, when you've groin pain during sprinting, for example, how much of that groin pain is because of the swing leg, you know, the adductors, the hip flexors, the obliques as they do it, and how much of it, even though the pain is on the, let's say, my right side, how much of it is biomechanical deficits on the contralateral side, the pain-free side, and how the compensations on my stance leg are leading me to overload my swing leg. And so I think what I really took from the program, from the conference in general, was that ability and that need to be holistic. And if you are, those trickier cases have a greater clarity and momentum to them.
Cool. No, really well said. And I'm curious, I got a lot out of listening to you in your talks at Sportsmith, but when are you next kind of doing workshops or live events? I'm just kind of, from a listener perspective, if they haven't caught you, just want to kind of give them put your calendar on their radar.
Yeah. So, given that I'm based in Doha and my family are based in Dublin, travel is a challenge at the minute. But we're over to Australia for the Sports Medicine Australia conference in Hobart in November. So very much looking forward to that. We've been over to PSG recently, and we'll have another event with them very, very soon, just waiting for confirmation. And then we've our large Aspidar Congress, which will be hosted here in Doha in October. Last 2 years, we've had a very rehab-specific focus. Year one on ACL rehab, and last year on thigh muscle injuries. But this year it's more multidisciplinary process. So they're the kind of the big events between now and Christmas. I have a couple of workshops with my old colleague Eamon O'Reilly in Spark in Dublin in December, and then we'll go downhill until Christmas and then see how we go from there.
Cool. It's a busy tour by the sounds of it. We'll put links to your social media connections and all that stuff in the show notes as we normally would. But it's been an absolute pleasure to interview you today and get to chat to you and talk